afternoon, everyone. My name is Diego Ortiz, and on behalf of the American Heart Association, it is my pleasure to welcome you to this special Pride Month conversation, Hearts with Pride, Advancing Heart Health for LGBTQ plus adults. You know, for far too long, the public health crisis of health equity has taken a painful and unacceptable toll on the health and well-being of LGBTQ plus individuals. While some progress has been made, LGBTQ plus adults in the United States remain a marginalized group with a significant health disparities compared with their heterosexual and cisgender counterparts. The AHA, we strive to save and improve the lives of all Americans, and we know that all Americans includes people of all backgrounds and across the spectrum of all diversity elements, sexual orientation, gender identity, age, race, ethnicity, faith, socioeconomic levels, and physical and cognitive disabilities. We hope that this conversation celebrates Pride Month and helps create a better understanding of the unique challenges faced by this community so that we can continue to improve the health of every member of the community. And now we are very excited to welcome an impressive panel of experts and leaders who work tirelessly every day to improve health outcomes in the LGBTQ community as researchers, doctors, nonprofit and business executives dedicated to increasing diversity and inclusion. We want to express our gratitude right now for our two presenting sponsors, MasterCard and Westchester Medical Center. These two organizations are committed partners and champions for health equity. Thank you. And now I just want to walk us through what's going to happen during today's conversation. First, you'll hear from Dr. Cara Pensa. Cara Pensa is the Global Medical Director for MasterCard. And while she couldn't be with us today, she recorded a message for us before beginning her maternity leave. So congratulations, Cara, we can't wait to hear from you. Then we will hear from Mathilde Roman, Senior Vice President and Chief Equity, Inclusion, and Diversity Officer for Westchester Medical Center Health Network, who will talk about their commitment to increasing health equity. And then we will hear from Billy Caceres, PhD, RN, a researcher from Columbia University and the author of the American Heart Association statement on the impact of discrimination on heart health in the LGBTQ community. And finally, I'm so excited that we're going to welcome all of our guest panelists for a round robin discussion where we will attempt to cover as many topics as possible before we reach the top of the hour. Now we have a lot on the agenda in only a short amount of time. So now that we've set the stage, let's welcome Dr. Cara Pensa.
Hi, I'm Dr. Cara Pensa, an internal medicine physician by training and MasterCard's first ever global medical director. While I'd love to be here with you live today, I am currently on my parental leave, but was fortunate to film this video introduction just a few weeks before the birth of my second child. It is my pleasure to welcome you to today's webinar because it's the beginning of a wonderful relationship with the American Heart Association. As a corporate medical director, my position within the organization is to support and enhance the health and well-being of our employee population worldwide, which is in direct alignment with the American Heart Association's mission to be a relentless force for a world of longer, healthier lives. Everything about the Live Fear Stand for All platform spoke to me and is in sync with our goals at MasterCard of supporting diversity and inclusion, and the goals of my position in particular of driving health equity and supporting our employees' health and overall longevity. By becoming a platform sponsor, MasterCard has the opportunity to engage in and support the AHA's work to advance strategic areas of action that are critical to creating equitable health for all. Together, MasterCard and the American Heart Association will continue to support historically excluded populations, address the inequities that women, minorities, and members of the LGBTQ+ communities experience in accessing quality healthcare, and connect communities and workplaces like ours with the tools and resources they need to support all their members in order to ensure racial, ethnic, gender, and women's equity. We know that people thrive when they feel they belong, when they feel that their ideas are valued, and when they know they're treated fairly always. Fostering equity and fairness is embedded in our DNA through the MasterCard way, which promotes inclusion and being a force for good to unlock potential for ourselves, our communities, and our business. We at MasterCard understand that individuals cannot reach their full potential if they are limited by health inequities and barriers to access and quality healthcare. This was just the introduction, and the goal is that these community conversations help us to elaborate and talk more about these topics in detail.
Thank you, Dr. Pensa. And now it's my pleasure to welcome Mathilde Roman.
Thank you so much for inviting me here to speak with you today. It's a pleasure to be part of this session among such a distinguished panel of experts. Let me begin by extending warm greetings from WMC Health CEO and President Michael Israel, and thank those in attendance for joining this important conversation. WMC Health is committed to improving LGBTQ people to live their healthiest life. And as a leader in cardiovascular health in the region, WMC Health recognizes the importance of ensuring that we provide a welcoming environment that affirms everyone's right to receive expert care they need most. Health equity is an important guiding principle at WMC Health, and we appreciate the strong partnership with the American Heart Association and our common goal to addressing disparities to better health outcomes for LGBTQ people. Because evidence shows LGBTQ adults are more likely to experience negative health outcomes due to structural inequities and face disparities linked to societal stigma and discrimination. As described in the National Academy of Medicine's report on LGBTQ health, LGBTQ adults face stressors linked to discrimination and bias-motivated violence that negatively affects their health and well-being. And research suggests that LGBTQ adults experience worse cardiovascular health related to their cisgender heterosexual peers, which is driven by exposure to stressors across their lifespan, according to a statement published by the American Heart Association. So today's session is aimed at not only discussing some of the root causes associated with disparities found among sexual and gender minorities, but also to explore best practices to address these disparities that can lead to improved cardiovascular health of LGBTQ people. But before we dive in any further, let me say Happy Pride Month. WMC Health stands proudly with the LGBTQ community and stands committed to providing affirming care to improve the health and well-being of LGBTQ people across the Hudson Valley. And as we celebrate the LGBTQ community's rich history and contributions, let us also remember the work that remains to make sure everyone has the right to choose who they can love, be affirmed for who they are, and receive the care they rightfully deserve so that they can live a full and healthy life. Diego, I'll turn it back to you.
Thank you, Mathilde. It's really a pleasure to welcome you, and I can't wait to hear more from you in just a few minutes. But before we get to our panel discussion, I'm excited to welcome Billy Caceres, Dr. Billy Caceres, to give us the overview of his important research. Welcome, Billy.
Hello, thank you. So first, I'd just like to thank the American Heart Association, WMC Health, and MasterCard for organizing this event. So as a cardiovascular researcher that studies specifically LGBTQ populations, this is a topic that I think about quite a bit. So I'm going to try and condense it all into the time that I have allotted. But the American Heart Association is one of several national organizations that recognize the important role that social determinants play in shaping the cardiovascular health of marginalized groups like LGBTQ people and people of color. So in 2019, the American Heart Association asked my colleagues and I to develop a scientific statement on the cardiovascular health of LGBTQ adults, with the primary goal of providing suggestions to improve cardiovascular research and cardiovascular care for this population. But before I discuss the findings of the scientific statement, I think it's important to discuss some of the potential reasons why these disparities exist among LGBTQ people. So a lot of the time people ask me, well, why would LGBTQ people have worse cardiovascular health than the general population? And the answer I wish was simple, but it's simple and also complicated at the same time. So most cardiovascular health disparities, including those among people of color, are really attributed to social determinants of health. I always get asked about, well, is it because of the higher rates of HIV among gay and bisexual men? Is it because transgender people are on hormones? Is that the reason they have higher cardiovascular risk? And I think that the focus on HIV and hormones, I think, is important, but I don't think we should minimize the role of social determinants. And social determinants of health are defined as conditions in the environments where people are born, live, learn, work, and play that affect health outcomes and risks. So these include things like exposure to discrimination, poverty, living in a violent neighborhood, and availability of fresh fruits and vegetables, all of which have been associated with worse cardiovascular outcomes. I think we really need to I don't think it's hard to sort of see that in our country, and not just today, but throughout our country's history, the everyday lives of certain individuals are just more stressful because of the things that they have to deal with. And the LGBTQ community is no exception to that. So among LGBTQ people, we see many of the same social disadvantages that we see in other health disparity groups. For instance, socioeconomic status is an important social determinant of cardiovascular health. And we have growing evidence that LGBTQ adults, particularly bisexual and transgender people, and really people of color within the LGBTQ community, are about twice as likely to live in poverty and to delay healthcare because of fears related to costs than the general population. The most widely accepted explanation for the disparities that exist in this population is greater exposure to minority stressors, which are these unique stressors that people experience due to their minoritized sexual orientation or gender identity, which negatively impact their health. The most commonly recognized minority stressor, which we talk about a lot, is experiences of discrimination. So we know that LGBTQ people are much more likely to be treated unfairly because of their sexual orientation and or gender identity. But these minority stressors also exist at the policy or structural level. So when same-sex marriage was legalized at the federal level in the United States in 2015, many people thought that this was sort of the end-all be-all of LGBTQ rights. However, there are still many battles that need to be fought, including policies where discrimination against LGBTQ people in healthcare settings and public spaces is not considered illegal. And in fact, more than half of the states in the United States do not have hate crime laws that protect LGBTQ people. So in the scientific statement, taking all of that together, we basically found that many groups within the LGBTQ community face higher risk of cardiovascular disease, but this risk is not created equal across groups, with higher cardiovascular risk among women, transgender people, and people of color within the LGBTQ community. We looked at risk factors that are included in the American Heart Association's Life Simple 7, which includes 3 health behaviors and 4 health factors. And what we found was that LGBTQ adults were much more likely to smoke than heterosexual and cisgender people. Lesbian and bisexual women had higher rates of obesity and diabetes than heterosexual women. Bisexual men were at higher risk of obesity, high blood pressure, and diabetes than heterosexual men, while on the other hand, gay men were much less likely than heterosexual men to be obese. We have much less evidence on physical activity and diet, although there are many studies, even in the last 2 years since we released the statement, that are focusing on these topics. We did find that the research evidence on the cardiovascular effects of hormones, which is really what I'm asked the most about among transgender people was really mixed, and we really need more rigorous research to understand the influence of hormones on the cardiovascular health of transgender people. We also identified major limitations in existing research, including limited examination of the impact of social determinants of health and cardiovascular health of LGBTQ people, and a focus primarily in research on white LGBTQ people. Overall, although we know a lot more about cardiovascular health in this population than we did a decade ago, there are still many unanswered questions. And we concluded that really to improve the cardiovascular health of LGBTQ adults, we need clinical and policy interventions that reduce barriers to achieving optimal health. And these are a bit complicated because they require collaboration with people across various sectors, including healthcare professionals, policymakers, and LGBTQ community groups to really bring about sustained change. Thank you.
No, Billy, thank you for helping us define so many of these terms to set this conversation, to open this conversation, and really all of the phenomenal work you've done on behalf of the American Heart Association. We're just thrilled that you were able to join us. And I'm also really excited because we're about to meet the rest of our panelists. We've met Mathilde, we've met Billy. Now let's introduce you to Dr. Rebecca Glassman from WMC Health Network. She's the medical director of the Ally Care Center and another leader in the community. We're excited to welcome Judy Troilo, the executive director from the Loft LGBTQ Community Center. Welcome to all of our panelists, and I invite Billy and Mathilde to come back on camera. There we go, there's everyone. You all look great. And before I ask the first question, I want to encourage attendees, if you have questions, please type them into the chat box. While we do have some pre-prepared questions, if we have time, we'd like to include your questions as well, and maybe there's an opportunity for them to add to this conversation. Well, let's get into it, because this is really what the core of today's presentation is this panel discussion. I'm going to address the first question at you, Mathilde, but I welcome the rest of our panelists to join in. You don't have to raise your hand. I'll ask you to be polite, but without a doubt, I want to hear from all of you. But Mathilde, in recent years, there's been more research that illustrates how social determinants of health, such as limited access to affordable and safe housing, healthy food, and quality healthcare, can affect the quality and length of one's life. Now, LGBTQ adults face higher rates of poverty than their heterosexual counterparts. How can corporations and health systems help address the social determinants and create longer, healthier lives?
Thank you for that question. And I think that Dr. Casetta has really provided a really good overview for the audience. And for me, part of the work that we do at WMC Health is really focused on how do we increase the social, increase access and equity in the delivery of care, but also looking at a broader spectrum of how we inform the communities and engage with the communities thoughtfully to really help support our LGBTQ people in the Hudson Valley. And that is done from a number of things. It's really having, strong partnerships with community-based organizations like the Loft, and also thinking about how do we meaningfully engage with members of the LGBT community to really hear their needs and what barriers they face when seeking care. The other big aspect of this is really kind of figuring out what screening mechanisms we can put in place to ensure that we are truly addressing the needs of the LGBT community in a meaningful way so that they can really thrive within, within the communities in which, we're called to serve. And I'll invite other members of the panel to also add to those comments.
Well, I think we're going to be able to touch on these topics as we continue the conversation. And Dr. Glassman, research suggests that members of LGBTQ communities face health disparities linked to societal stigma. Billy mentioned some of them: the discrimination, the denial of civil and human rights. How have you seen this impact the patients you serve, and how can we work to address discrimination in healthcare settings?
Yes, I agree that Dr. Caceres outlined it so beautifully for us. I think one of the things that we see is a delay in care for many patients that stems from the discrimination they've previously felt. So I think really for the healthcare system at large, we need to work to ensure that our hospital setting, our electronic medical records create an inclusive space. And as individuals, we need to ensure that for every patient, we introduce ourselves and ask patients to introduce themselves to ensure we know preferred pronouns, preferred names. And as we take social histories, we ask open-ended questions that avoid the binary assumptions. Because as soon as we do that, we find that we close ourselves off to a patient, and we're not going to be able to get at the core of what their needs are. As a medical educator, it's important that as we train future physicians, we assure that they are also learning to address social histories in a thorough and open-ended way. And as Dr. Caceres was addressing as well, that they're integrating social determinants of health into a conversation with every single patient, not just those that we might assume to be struggling in one way or another.
And Billy, I welcome you to help elaborate, just from what you've seen and reading all of the literature and working with your colleagues on the statement.
No, I think Dr. Glassman covered a lot of the important topics. I think that organizations really, one of the things that's happened over the last decade is that now that we have these great electronic health records that have the capability of having fields about sexual orientation and gender identity, there's sort of been this push to assess these in clinical practice without really educating the physicians and the nurses and the other providers that are working in a clinic or a hospital about why should we be asking about these things. Like, I remember I was working in clinical practice as a nurse when my health system that I worked at implemented these, and somebody asked me, well, if this patient's here for a broken leg, why should I be asking them about their sexual orientation and gender identity? But I think it's really important that we create these, as clinicians, we talk a lot about creating therapeutic relationships with our patients. And I think that if patients feel like they have to hide a certain aspect of themselves, which is really important to their overall lives, like their sexual orientation, that I think that automatically creates opportunities for miscommunication, mistrust between healthcare providers and patients, which I think is really important. I think organizations can do a lot more to sort of create more trusting relationships between patients and providers, at least from a clinical perspective.
And Judy, I know we had kind of touched on this subject when we chatted in preparation, but we want to hear from you because we're excited that you join us. Why don't you tell us a little bit about your role and the role of your organization, and then we'll talk about some of the training that organization has provided.
Absolutely. But I first, if it's okay, I want to acknowledge, Dr. Glassman and Dr. Caceres. The information they're providing is so vital. That being said, I think it's also important to recognize that the frontline staff in any medical facility needs to be properly trained. And that when you're talking about, because that's going to be the first exposure someone has. If they have a bad experience, they may not come back or they may leave. And it's also creating an affirming environment where they feel comfortable enough to share that information on gender identity and sexual identity. Because if I don't trust you, I don't know that I'm going to talk about those parts of my life with you. So trust is important. Education and training, not only for physicians and nurses, but for the intake coordinators and the folks on the front line. As far as what the Loft is doing, we're an LGBTQ plus community center that's been around 40 years. we started as in response to the AIDS epidemic, and how people needed a safe space to come. It started in 1983, and feel welcome and get answers to questions and not feel judged. With that being said, that kind of is what we're built on, creating a safe space. Our mission is to advocate, educate, and celebrate. So we advocate for individuals, whether they've had a bad experience with a healthcare provider, or they're looking for an affirming healthcare provider, or their rights have been violated. We also advocate on a national level for LGBT affirming policy and fight against policy that discriminates. We educate. We work very closely with Westchester Med in educating their staff on cultural competency specific to different areas of the community when it comes to the human experience. You know, we turn to folks like Dr. Glassman to talk to us about the medical aspects of things and to speak about that. What we can speak about is how people feel, how they're left feeling. We have groups, we have peer support groups, we have mental health services, we have grief and loss groups, and we house self-help groups, which are really important because when we talk about alcoholism, addiction, smoking, people need to have a space where they feel safe and they're among people that might understand their unique stressors. So.
Thank you, Judy. I want to give an opportunity for anyone who's following along to take a look at our chat box. I do know that, that Jeffrey from the Loft was going to share some useful links. There's an opportunity to learn more about the wonderful work that you do, the many programs and services that you provide, education, mental health, counseling. It's just a phenomenal organization. So thank you so much for sharing a little bit about what you do with us and your five decades of service to the community.
Thank
Billy,
you. And we work with Westchester Med. We worked all through COVID together on vaccinating folks. And with our HIV programming, we also have One Voice, which is an HIV support group. But Dr. Glassman's team does testing for us, which is really important because the testing they do is free to our community when we're at community events, and that addresses some of the issues of affordability. So,
you know, as long as we're talking about the vaccination and the coronavirus pandemic, which we're still living in, let's get into it a little bit then. So reports do indicate that the LGBTQ community was particularly vulnerable to the coronavirus pandemic. Mathilde and Judy, why was that? And what did the health systems and nonprofits learn from this experience as leaders during the pandemic?
So I'll kick it off. So, you know, there's a number of lessons learned throughout the pandemic and understanding the disproportionate impact that LGBTQ people had during COVID. You know, there was, you know, displacement of, you know, income due to economic displacement that I think is important to note. And, you know, given how we had to lock down, there was also access issues with, you know, getting primary care, but also kind of care for TGNC, for hormone therapy that was needed. And so those are the salient kind of things that occurred during COVID. I think, you know, one of the immediate responses for WMC Health was to build a health equity task force and bring people together to really identify these kind of stressors that were happening among the communities of color and in the LGBTQ community. And for those reasons, then create intervention strategies that really help drive the access and kind of deep get those access issues addressed, as well as looking at things with respect to vaccination hesitancy or education that was associated with the vaccine, or even with respect to COVID, and how are we really communicating out to communities in a meaningful way, was something that the Health Equity Task Force that was done across the Hudson Valley really was pinnacle in making sure that we were in real time addressing the needs of marginalized and vulnerable communities.
And I can add to that, I was part of that task force, and we did really important work in identifying, especially when it came to vaccine hesitancy and making vaccines accessible to folks. But I think a lot of our folks, we intersect with everyone. I mean, we're everywhere, and we're part of every community, and then we are our own community. So you have different factors coming in, but I would say, underlying conditions, when you listen to what Dr. Caceres was saying about being, we experience higher rates of, smoking, addiction, heart disease, depression, those stressors that add to, discrimination, loneliness, those things weigh heavy on your system, on your heart. And our older folks, a lot of them live alone. And we tried really hard during COVID to provide them with food and actually pick up their prescriptions. And so people who are alone and don't have access and family support, I think that was difficult. But as far as having comorbidity, when you have underlying conditions, when you have HIV, those things, it was deadly for all of us in the beginning, but there were extra concerns for our community. But we've also been reminded by many of the folks that are living with HIV and lived through the epidemic, the AIDS epidemic, especially in the early 80s. They'll say, we've been through an epidemic before. We're strong. We know how to deal with it. But that's sad, but it's the truth.
Judy, I appreciate you for bringing up, the topic of HIV, because it is important to note that HIV is associated with an increased risk for cardiovascular disease. Dr. Glassman, I want to invite you to discuss this topic with us and tell us how you've seen this connection with HIV, heart disease in your patients.
Yeah, so we most definitely do see an increase in cardiovascular events in our patients living with HIV. And it is in line with the data, which shows nearly a twofold increased risk. So Dr. Caceres outlined life's simple 7 ways in which we can improve our cardiovascular health, which we take into account with every single one of our patients. But specific to HIV infection, we know that there's also multiple ways in which HIV can increase the risk. One is that HIV infection causes systemic inflammation, which targets the arteries. And so that can be reduced when patients are taking their medication, reducing their viral load, reducing the inflammation. Older antiretroviral drugs did increase cholesterol levels, but luckily, really the mainstays of treatment today don't cause this effect. But in patients who have been living with HIV for decades now, they may have suffered the ramifications of older generations of antiretroviral drugs. And lastly, as we've already touched upon, there is a higher incidence of tobacco use in people living with HIV. So, as a primary care provider serving patients living with HIV, I need to stay attuned to this increased risk, because when we look at risk calculators helping us to know when to initiate a cholesterol lowering medication, we aren't taking into account that inflammation from HIV and the older generations of medications. So we have to think, maybe we need to screen more frequently. Maybe we need to add another factor to when we would initiate medications. And I do think that we will have some really important results of great research going on right now in the population of patients living with HIV to help guide these decisions moving forward.
And I'm so glad that, we're discussing research. The American Heart Association, our role has been funding research. We're one of the top funders nationally and globally of cardiovascular disease and stroke research. Billy, we've talked a little bit about the importance of representation. Representation is fundamental to all communities. But the LGBTQ community is not being properly represented in research. You talked about that a little bit in your opening. What can be done to help improve this and accurately study health and disease in the LGBTQ community?
I think this is a really important question. So it's an important issue, but I think it requires consideration of people's intersectional identities. So I think it requires consideration of, okay, so we're recruiting LGBTQ people, but if the people that you're recruiting are high income, highly educated, white, and all female, let's say, I'm just picking identities, then are those findings really that useful for the populations that experience the greatest disparities really across all health outcomes, right? People that are poor, people that are people of color, transgender people. So I think when we think about representation, it needs to be thought of in a number of different ways. So representation in terms of research participants, I think it's actually easy enough to do when you develop trusting relationships with community partners and with members of the community. So if you're going to now, especially if you're not a member of the LGBTQ community, you're now doing LGBTQ research, making sure that you're partnering with people from the community that really are keeping you honest in terms of the way that you're representing the data, the questions they are asking. I think that there's been a lot of reticence from researchers, and I think probably more cardiovascular researchers, truthfully, than substance use researchers or HIV researchers, of incorporating questions about sexual orientation and gender identity. There's still, I think, a gap in the knowledge of healthcare providers and health researchers sort of about why is it important to ask these questions. And it's interesting because I've participated in some studies where they originally didn't ask about sexual orientation, and then we added sexual orientation later on to the study. And we found something like 10% of the people in this giant study of 1,000 people identified as LGBTQ, but we would have never known that had we not asked the question. So I think asking the question is important. But I also think it's important to make sure that there's not only representation among research participants and the people that in the communities that are represented, but making sure that the research teams reflect the communities that they're studying. So as somebody who is a person of color and identifies as gay, but I'm also male and I'm not transgender, I have done studies that focus on lesbian women or transgender people, but always making sure that the researchers that I'm partnering with are members of the community, have expertise on the community, and that they're making sure that I'm not somehow misrepresenting or misinterpreting the findings. And I think that one of the things that's been nice, I think, with greater awareness of these issues, is that I have been a little bit more emboldened when I find myself in situations where I feel that the voices of transgender people or women aren't being represented in the research team, to say, well, if they're not represented, then I'm removing myself from the situation. And I think in large part because of the sort of the American Heart Association's support of this work, I think that it sort of increased my standing as an expert in this area. So maybe 3 years ago, I probably wouldn't have felt like as emboldened to say, well, if you don't add X, Y, and Z people, then I will not be part of a research team. But I think that that's also really important. It's not just about the people represented in the research, but also behind the scenes, because that, although we don't think of it always, people from the community are looking to see if they recognize the names of people that are part of an authorship team, or they're recognizing people that are out there representing this research at conferences or in the community. So I think representation is really important, particularly for those of us who might have some identities that are privileged identities, some identities that are more minoritized. It's a constant sort of push-pull that I think is not just unique to me. I think other people deal with this a lot too.
Well, Billy, and I appreciate you for saying that. And I want us to take a moment to elevate and highlight the transgender community right now, and talk specifically about what are some of the health threats that the transgender community is facing that might be unique. Rebecca, Judy, Matilda, if you want to come back into the conversation, Billy, I'd love for us to just take a moment to shine the spotlight on the community. How about Rebecca to get us started, Dr. Glassman? I think you might be on mute.
I'm so sorry. I'm having trouble hearing there for a second and also unmuting. Could you just really briefly repeat the question, Diego? I apologize.
Yeah, I want us to have an opportunity to shine a spotlight on the unique challenges or the unique realities that the transgender community is facing. So can you tell us about any specific health threats that transgender men and women are facing? Thank you so much, and my apologies again.
I think I'd go back again to delay in care, and I really want to emphasize that. And I really liked what Judy said about just the entrance into a medical visit and that whole check-in process. I hear time and time again from my patients that they've been misgendered, called by the wrong name, not have the appropriately labeled bathrooms or not know which to choose. And so when we start with our patients in this vulnerable position, they cannot trust us with their health concerns. They can't open up to us about what they need. So what we aim to provide is really continuous access to comprehensive care. And this may include gender affirming hormone therapy, but that needs to be safely monitored by us in the health community. It also means access to mental health care, not because being transgender is a mental illness, but because of the significant discrimination and challenges that they have faced in trying to be themselves. So this just can't begin until we've created a safe medical environment that ensures that patients feel safe walking through our doors. One of the ways our team has been trying to reduce this barrier is by going out into the community. And we're so grateful for our partnership with the Loft, enabling us to attend many of their events where we can educate the population and help connect to them in a comfortable place in their social home, so that when they're walking in the door, they know who they're going to meet. And hopefully they can feel more comfortable opening up to us about their needs.
So I just wanted to make a point, because I alluded to this earlier, but every time I give a presentation on cardiovascular disease in LGBTQ people, even if I'm not talking about transgender people, I always get asked about hormones and cardiovascular health. And I think the point that I want to make, and that I always make when I'm asked this question, is that we know that hormones, the use of gender affirming hormones, is associated with many positive health effects. It's associated with improved quality of life, mental health, and there's some evidence even to show that's associated with improved physical activity. But I think we often focus on sort of like all of the potentially negative things, which we actually don't have that much concrete research evidence about. So I think that within the context of transgender health, I think that there's some myths sort of about hormones and how they influence health, and that we know we have definitive answers about these things. And I think a lot of the research around physical health outcomes is really sort of evolving. And I think exactly the issues that I talked about before, it's about having representative samples of people in studies that represent the diversity of the transgender community, representing transgender women, transgender men, people with non-binary identities. So I just think when thinking about transgender health, I think that's an important consideration.
Yeah, thank you for that, Dr. Caceres. And I couldn't agree with you more, Dr. Glassman, but I will add that you are talking about hormones in relationship to cardiovascular health. Even if, look, our TGNCNB community, our trans and non-binary and gender non-conforming community, when it comes to identity, more specifically, trans women, trans men, this is their identity and their life. And many people would rather die than have to give up their hormones, you know? So if it is a myth, like when we talk about the correlation of hormones and cardiovascular disease, perhaps there are members of our community that if they have chest pains, they're afraid to go to the doctor because they're afraid that they may be taken off hormones. So you're absolutely right. Educating folks, working with them, meeting them at where they're at is super, super important. That's what I heard from that. And as far as trans folks go, I will tell you that I hear more bad experiences from our trans community with frontline staff during the intake process or utilizing a bathroom. I very rarely hear complaints about the doctors they see. It's usually about the experience getting in to see the doctor, or when they undergo a medical procedure, if someone undergoes any kind of medical procedure, the experience they have maybe in recovery and being misgendered. I mean, that's huge, traumatic. And I think we have to look at our healthcare system beyond the direct medical care and more about the people that are surrounding and interacting with the community.
Thank you all for those responses. Matilda, I want to bring you back into the conversation because you have such an important role, in my opinion, as the Chief Equity, Inclusion, and Diversity Officer for a major health network, WMC. And we know that there are barriers that the LGBTQ community faces. In your role, how can you help break down some of those barriers, first for your employees and also for the communities that you serve?
I think many of the panel members kind of pointed to a number of things that could be done, and this is the kind of work that we're doing here at WMC Health. Is really about, you know, how are we educating frontline staff, right, and how throughout those key points of contact we're really building capacity for providing culturally responsive and affirming services, right, at every point of contact. And so whether it's at intake or registration, or even engaging with security officers, and really creating also what I would identify as visually affirming spaces within key areas that really help. Like, I've heard from LGBTQ community saying that a simple, you know, rainbow flag and at the front desk really goes a long way to kind of at least provide a sense that, okay, this may be a place that could be affirming for me. And so for us, it's really important for us to really create an environment that is accepting to the LGBTQ community, and also build capacity for the delivery of services that really provides respectful encounters to meet their needs, so that when they get to Dr. Glassman for care, you know, they feel that they can continue to return back and receive primary care and comprehensive services within the healthcare environment. And that's critically important. I think the other piece of this is really how healthcare institutions can really strive to make sure that we are creating feedback mechanisms and loops for the community, so that we're hearing firsthand on when, you know, as much as we could do with respect to policies and education, that we're really creating mechanisms where we're allowing the community to tell us what's going well, but also what's not going well, because that's where, you know, we can make the necessary adjustments in our models in order for us to be able to course correct and really provide that affirming space that, you know, they rightly deserve. And so that would be the things that we're working on here at WMC Health with respect to education, looking at creating spaces that, you know, are visually affirming for individuals, and really engaging with the community in a meaningful way, so that, you know, when you know, they know that we're a trusted environment and a source for them, and they can come to us to tell us if things aren't going right, so that we can then make those adjustments and make sure that they're coming back.
Thank you, Matilda. And, you know, looking at the clock, knowing that, you know, we only have about 10 minutes or so to wrap up the conversation. I still want to touch at least two more topics. And one of them we've kind of touched a little bit upon, and that's around our life simple sevens. Those are controlling things like blood pressure, cholesterol, blood sugar, our weight, our nutrition, physical activity. And the biggest one the doctors tell us all the time is stop smoking. And research shows that there's increased use of tobacco and substance abuse in the LGBTQ community. Judy, I'll ask you to start. Can you tell us about the importance of cessation and addiction programs?
Sure. I mean, obviously, those are important programs across the board, but to have them within an LGBTQ plus center or organization where the participants are having it's relatable. You feel you can be your whole self and talk about your stressors. Those programs are key. Self-help programs within the LGBTQ community are, crucial, vital. We provide a space for self-help groups, and they're really well attended. And that's a good thing, because that means people are supporting each other. So the support that folks get from each other is really important. We all know that cigarette smoking is bad for our health, we've been told that our whole life. But to have someone sit and speak with you about, I understand how hard it is. Let's talk about ways that we can address this and support each other. So I would say it's paramount to have community support. We find that our peer support groups are the most effective groups for our folks, because it's relatable. You feel like a sense of community, and hopefully we're creating a non-judgmental environment. And I think those programs, hopefully people don't feel judged when they're among their own folks. So.
Thank you, Judy. Dr. Glassman, how about you?
Yeah, I think tobacco use needs to be addressed as any other chronic illness. It needs to be addressed at every single medical visit. For individuals who aren't ready to quit, it's our job to explain why we feel it's important to their health and figure out what it is that continues to drive them to continue to smoke. And for patients who are ready to quit, we need to provide medications to assist their efforts, schedule close follow-up to check in, change the course if it's not working. It's a longitudinal process. And the medical team needs to be along for that journey as a partner, just as a peer support group should be as well.
Thank you so much. And in the interest of time, I'd like to give all of the panelists an opportunity to leave us with, a parting thought. I kind of had two questions I wanted to combine into one. And Dr. Glassman, since we're on you, I'll ask you first. How can other members of the community and allies help? Or what do you hope the legacy of Pride 2022 will be?
I hope the legacy of Pride 2022 is inclusion. And I think if all members of the healthcare system can develop non-binary, open-ended questions for every single patient, we'll create an inclusive space that ensures our patients see their entire medical team as an ally.
Judy, the same question to you. How can members of the community and allies help? Or what do you hope the legacy of Pride 2022 will be?
I knew that would happen at one point, all right? The legacy of Pride 2022, I mean, my gosh, it goes beyond health for me, because this is about our community as a whole. Equity, inclusion, diversity, understanding, compassion. what I hope the legacy will be is where there's strength in numbers, that we can combat hate with compassion, that we need to stick together. We have a long road ahead of us. So this isn't we're not, basic human rights is in jeopardy for our community right now. So I'm hoping our community is galvanizing during this time. As far as health goes, seeing panels like this and having the American Heart Association in partnership with Westchester Med and MasterCard come together to do a panel like this during Pride Month is hugely important. And we've come far to be able to have this discussion. So I hope we continue along this path. I think that allies are key, because I'm looking at this panel. I think some of us on this panel are queer and some of us aren't, I know. So our allies, along with the LGBTQ plus community, it's the only way we get stuff done. So.
Well, thank you, Judy. Matilda, I want to give you the penultimate word. Tell us how can other members of the community and allies help, or what do you hope the legacy of Pride 2022 will be?
These conversations, to Judy's point, are critical. So one, continuing these conversations and having these conversations turn into action. And the legacy, I hope, is that we get one step closer to really addressing the social determinants and the disparities and inequities that exist for the LGBTQ community, and so that we're not having this conversation any longer. That would be my hope.
Thank you so much. And Billy, as the lead author of the American Heart Association statement, I want to give you the last word. So take it away, Billy.
I feel like I have to end with something super philosophical, but I think I will say that for me, although I talked a little bit before about anti-discrimination laws and hate crime laws specific to LGBTQ people, knowing what we know about poverty and access to healthcare among LGBTQ individuals, particularly transgender and bisexual people, it's that we need to galvanize the community and sort of be invested in political advocacy and in making sure that policies are equitable, not just policies specific to the LGBTQ community, but policies for income equality, for access to healthcare are disproportionately going to advantage minoritized people like LGBTQ people and people of color. And I think that it's about bringing people together, accepting help from allies and making sure that we are educating allies to have the right language and be able to communicate with members of the community in appropriate ways. But I think when I used to teach graduate research course, the students hated when I said this, but healthcare is inherently political because our healthcare is determined by policies. So if we care about the health of these communities, we need to actually be involved in some political action of some sort. And I think that's far-reaching. These policies have far-reaching impact. So I know in the chat there was a question about these don't say gay policies in Florida. The don't say gay policies in Florida aren't just harming people in Florida. They're also harming the LGBTQ people in other states, right? So policies against that limit healthcare for transgender youth. I, as someone who's not transgender and I'm in New York, I'm not in a state, I'm still impacted by that. And I think a greater recognition of how these policies, even in a particular state or jurisdiction, have far-reaching effects for people of the community and people who are allies of the community. I think there needs to be greater recognition to that and of that. And I think that that should unite us in terms of fighting for these, for equal rights, and really the rights of other marginalized groups are just as important to be fighting for. So yeah, I think that's what I hope the legacy of 2022 Pride is.
Well, I want to take one more opportunity to thank our speakers and panelists, Dr. Cara Pensa for her pre-recorded message, Matilda Roman for sharing with us WMC Health System's connection to this movement, Billy Caceres for all of the great work you've done on behalf of the community for the American Heart Association, Judy Troilo for your leadership across Westchester and across our region, and of course, Dr. Rebecca Glassman for the work you're doing directly with patients in our area. It's been an honor to learn from each of you. I also want to take one more opportunity to thank our presenting sponsors, MasterCard and Westchester Medical Center, for their commitment to promoting health equity. And finally, thank you, our audience, for tuning in. I know we're just about at the top of the hour, but you hung in there with us, and we really appreciate you for tuning in. Happy Pride, and let's continue to work together to build a world of longer, healthier lives for all. Thank you, and enjoy the rest of Pride. Bye, everyone.